Everyone can hear me all right. Let me introduce myself. My name is Shehzad Niazi, and I am a senior associate consultant at Mayo Clinic. And my subspecialty is consultation liaison psychiatry or psychosomatic medicine. And in that subspecialty, I work in the tertiary care division, and most of my time is spent working with the transplant services, hematology, oncology, and I lead a group for integrated behavioral health. Just a disclaimer about this talk. Some of the medications that I will mention in passing are going to be the indications that are considered off-label usages of these medications. What it means is that in US, any medication that has been FDA approved for a specific indication is considered a medication which is properly used, and for that indication, the clinicians still use these medications for a lot of other indications, but they're considered off-label usages of these medications. I don't have any financial disclosures in a sense that I'm not getting paid to do this presentation, and there is no industry support for this particular talk, either in presentation or during its telecast. I'm a Mayo Clinic physician, so obviously anytime I say anything about the Mayo Clinic, just kindly take that into consideration, because obviously inherently some of those statements could be potentially positively biased towards the clinic where I'm working at. Just some credits and acknowledgements. Obviously our department of medical graphics, they do an awesome job in helping us with the digital assets, anything that we need. The photographs that are going to be used in this presentation are from the stock agencies called thinkstockphotos.com, and our Mayo Clinic has an account with them. Then the transplant service staff itself is great. It's a pretty complicated service, and we have lots of support service available, and without their help, data collection and analysis wouldn't be possible at all. I definitely need to take a moment to thank you, Apna's merit program. Apna does a lot of wonderful things, but this particular program I really like because it allows some of us who are unable to help in other ways to at least try to share a few things that we are doing here, and hopefully can be of some help to some of our junior colleagues in medical school and some of our colleagues who are already done with that. I would like to take a moment to thank Daniel Rausab, who's providing out IT support and is up late at this hour in Canada. So thank you very much for that. Now, when I was approached to do a presentation, I obviously thought about various different things that I could potentially speak about. And then I decided to choose this particular topic for 2-3 reasons. One was obviously that this is an area in which I spent quite a bit of time. The other reason was that when I decided to pursue psychiatry when I was in third year of my medical school in King Edward Medical College, at that time, the thought about pursuing psychiatry was a little bit discomforting, because at that time I didn't know a whole lot as to what kind of practice opportunities would be available once I get done with this. And I hope that I will be able to share a few things, and if someone who is third year or fourth year final year medical student thinking about pursuing psychiatry might find it a bit intriguing and interesting, and knowing that even if they were to pursue psychiatry, they could pursue CL type psychiatry or psychosomatic medicine and subspecialties that allows them to still stay in touch with one of the more recent type of things that people are doing. So that was the other reason that I decided to speak about the transplant psychiatry and specific issues related to the organ transplantation. It's a pretty heavily regulated system, the way it works, and especially the solid organ transplants in the United States, there are very specific criteria as to how you list the patients, when do you unlist them, when do you put them on status 7 and things like that. And there are very specific guidelines about that. So it's not like that people can just jump the line based on who knows whom and stuff. Just a brief outline about what we're going to discuss today. First, I will briefly speak about the transplant service itself. We'll quickly review the issues related to waiting periods, and Mayo Clinic's data with the focus on Florida campus data. We'll speak briefly about the transplant psychiatry, its evaluation, and transplant-related psychiatric issues. In the end, we will have time for discussion, questions, and answers. I estimate that the presentation itself is going to last about 40-42 minutes or so, and so we'll have plenty of time for questions and answers. Just briefly, our Mayo Clinic has about 3,800 staff positions, 3,600 residents, and about 51,000 support staff, which includes the physician extenders such as advanced nurse practitioners, advanced psychiatric nurse practitioners, CRNAs, and physician assistants, and radiologist technicians, and stuff like that. So we have roughly 58,300 total people working together. This is the older data. Just in the last year, for example, for just at one campus, we have hired about 60 more physicians. In that larger organization, the transplant service is a horizontally integrated service across 3 centers. What it means is that if a patient were to come to Florida and see me, and then in a week later go to Arizona and be evaluated by a transplant surgeon there, and then go to Rochester to be seen by an ID specialist, all the data is shareable in real time, and we treat all centers as just like one center, and it allows us to pool resources and allows us to make policies that are uniformly applicable at each center. So Mayo Clinic Rochester, Mayo Clinic Arizona, and Mayo Clinic Florida are 3 campuses. This is just a distant view of Mayo Clinic in Rochester. This is our Florida campus. And this is one of the buildings here in Florida. This is just the outpatient clinic offices. And that's where one of my offices is. And it's just a beautiful place. And there's tons of artwork and display and such. And it's just really pleasant place to work. Just to briefly tell you as to the volumes. When our centers are combined, we are one of the world's largest centers for the solid organ transplant, especially when it comes to the liver. So the average, one data is that 4,314 liver have been transplanted in our centers. As you can see, most of them were done in Florida campus. We have transplanted at our center 1,394 kidneys so far, 375 lungs, 189 heart transplants, and 8 of them were, and then additional 8 heart transplants that were part of heart and both lung transplants. Obviously, that's a lot more complicated procedure, and that's why very few people do them, and that's why the number is limited. The selection criteria for those type of patients is very, very rigorous, as you can imagine. 242 pancreas transplants. We basically do all the solid organs and bone marrow transplants. We have not done face transplant at our Jacksonville campus, but everything else gets transplanted. Heart, liver, we spoke about. There's liver donor kidney, there were about 302, and kidney pancreas combined were an additional 121, and then VADs or LVADs, these are basically ventricular assistant devices that are used in patients who have cardiac problems, and either they are used as bridge devices, which means that you implant these devices while they are waiting for the heart transplant, or since the organs are so much in shorter supply that we sometimes use these devices, either LVADs or bivalvular VADs, as destination devices. In other words, patients can be maintained on these devices and sometimes don't even get the heart transplant done. As I was alluding to, it's a waiting game. Even when they get listed, any given time, numerous people are on the transplant list. So relatively recently, when I looked up the number, about 116,000 people were on the waiting list for the transplant. And basically, they get called, and in a very short notice, they have to get to the transplant center to get this taken care of. The window is obviously not too long. The organization that coordinates a lot of these transplant services and sets all the standards and policies for all the centers to follow is called UNOS, or United Network for Organ Sharing. It has divided the United States into different regions. There are total of 11 regions, and this red star is the state of Florida, and we are in region 3, and it has 6 other states. And there are significant variations across these different regions, and it allows a person to be dually listed or triple listed. For example, a person can be seen at Harvard or in Johns Hopkins, and then they can refer the same patient to us. We do the evaluation, and they get listed there as well. So wherever they get the chance to be transplanted sooner, they get the transplant done at that places. And if you look at this, there's a significant variation in the wait period. So if someone were to go to California, which is on the West Coast, and if they were to go to either UCLA or UCSF, they would be waiting 685 or 539 days. And then in Stanford, it is 468 days. If they were to come to the UNOS region here, where Florida is, and especially at our center, the wait period is 83. That's the 83 days. So as you can see, there's a tremendous advantage in that. And that's why what happens is that patients from California, either themselves or their insurance companies, they relocate these patients and their caregivers to our city basically, and they live here for a few months till they get their transplant done and get the aftercare done, and then we send them back and we coordinate with them. Even more amazing is the fact that the median time, just to take the example of liver, at our campus is 1.7 months after they get listed, which is not too bad. Not only that, if you look at the survival data, the outcome data, it looks pretty good. The national benchmark is 89.53%, and our survival rate at 1 year for liver transplantation is 94.05%. Which I find remarkable about this is this next slide, that it may not feel that much of a difference between those percentages, but what it translates into is that if you just were to look at the liver patients, that survival rate advantage translates into 226 additional patient lives saved. And these are obviously, all of these numbers are individual patients and their family members and loved ones that get to live basically. It's remarkable if you look at the age distribution, because at Mayo, some of these patients that get declined in other centers, we still consider them. And 28.7% of our transplant patients in liver category, 65 and above. We are in the process of looking at the data of patients who are 70 plus. And we have about 140 or so patients that we are going to be evaluating for the long-term data complications and longevity and such. And it's pretty interesting that we have so many of these patients. The idea is that there is no absolute contraindication based on the age of the patient itself. But if you compare our data with the other centers, as you can, if you were to just focus at this portion of this table here, 65 plus year patients at MCF for 28.7% of all the patients that we transplanted. And the US average is 11.8, and these are the equivalent size centers listed at Oxnard, Tampa, Miami, and regional averages. And so 28.7% patients versus 11.8 of US average. I don't anticipate that you guys would need to read all this busy slide portions, but suffices to say that this basically is the organizational chart of just one center's transplant service. And this red star denotes the Transplant Psychiatry, which is one of the subdivisions, just like transplant hepatology is, or transplant pulmonary or transplant nephrology services. It requires a lot of coordination between a lot of different physicians, and it comes down to collaborative work. We work together, and all of us have a good relationship with each other, and we have excellent record system. So basically what happens is that the patient, once they come to the clinic, they get appointed to see all of these patients' representatives who set them up to see different doctors. And we usually complete all the evaluation, including all the specialty and subspecialty evaluations, imaging studies, perfusion studies, nuclear studies, any procedures that need to be done. any kind of thing within 2-3 days or so. So basically, if, let's say someone is scheduled to see me at 9:30, and they are going to be here for the lab, and they have to have the radiology done, or they're going to see a surgeon, and they're going to come to see me. By the time they come to see me, all of that data is up and running in our system, and I have access to it. I complete the portion of my note and some of the rating scales while the patient are still in my office, and by the time they leave my office, check out, and check in at the next appointment, the notes and the recommendations and all the things that we discussed is available for the next provider. So that's how it gets done fairly quickly, and then there are several nurse coordinators who coordinate all the process behind the scenes. All the subspecialties that include, for example, the psychiatry, cardiology, nephrology, endocrinology, ID, they see the patients. But the surgeons, the hepatologists, and psychiatrists, we are part of the transplant board with all the other support staff. We basically meet once a week. So one day we have a 3-hour liver conference, then we have heart and lung meeting, kidney, pancreas is the other day. So in that, all the cases that were evaluated in that week, they all get discussed in detail, and we then make the decision based on the overall assessment as to whether patients can be listed, and if they cannot be listed, are we going to decline them, or are we going to say that, you know, this needs to be done, and then we'll reconsider them. So all those decisions get made, and everyone has input in that. The guiding principle for all of our services that we do is actually pretty simple. If you were to walk into any of the campuses of Mayo, you will see this code displayed very prominently everywhere, which is that needs of the patient come first and foremost. Our schedules are built around that. Our schedules are open for the rest of the year, and basically we just work things around the patient schedule, and that allows us to complete the workups at the pace that is convenient for the patient, as opposed to some places where everything is based on what the doctor's schedule looks like. Now, transitioning to the next portion of the transplant psychiatry, basically, in an essence, what we are doing is that we are evaluating their psychological, psychiatric aspects, any genetic predispositions, any coping issues, any psychological problems, any contraindications, any barriers that they have. And so that's where we come into picture. So let's just briefly give you some context for this discussion. So there are 14,630 listed donors, and this is the data from 2009. They update that a little bit later. This is from OPTN, which is the government organization that oversees everything. And there were 28,463 transplants that were done that year across the U.S. And the reason that there are less donors, fewer donors, and more transplants is because obviously there are people who donate more than one organ. That same year, after 28,000 people ended up getting the transplant, 105,000 people still were on the waiting list. So despite all the campaigns, all the dollars spent in promoting the organ donation, the number of organs available has been pretty much plateaued for the last few years, and it stays around 15,000, 14,000 available donors across the year. What it means is that out of several, only few end up getting the transplant. And these are the people who get listed, and on that list, not everyone ends up getting the transplant for a variety of reasons. And it is very critical fact to keep in mind, because for each person who ends up getting a transplant, there is someone else who wouldn't get it. So in other words, it's not a win-win situation. And that's why it is so critically important to ensure that we all work together to optimize the selection process. The idea is basically to select the best possible patient for the organ transplant. So the physicians who are working in transplant services, including transplant psychiatrists, they have dual obligations. We have to obviously keep the best interest of the patient in mind, and we also need to balance that with with graft protection responsibility. What it means is that if there's a patient who has hepatitis C because of intravenous use that he had been using for, let's say, 20 years, or someone has alcoholic cirrhosis because of a 30-year excessive alcohol consumption, and their period of sobriety is not too much, a month, 3 months, 6 months, they might not be as good of a candidate as a person who has cholangiocarcinoma and has never abused any drugs, has been a very productive and very responsible person, and otherwise healthy and very cooperative. That person would be a better candidate, realistically speaking. So you have to be basically balancing all of these factors, and you have to look at the overall clinical situation to get to a decision about when to list them, whether to list them, and how to address the barriers if there are any. And that's what we try to do when we are doing a pre-transplant evaluation. The purpose of that evaluation is that one of the things is that we are each person is individual and unique patient, and they have unique needs, unique challenges. So one purpose is to come up with an individualized treatment plan for that particular patient in that clinical context. We also carefully analyze and assess the caregiver situation, and that's part of the evaluation. We look at the personality traits of the patient and the caregivers. We very critically look at the past treatment adherence, if there are any barriers, like, for example, if there are transportation issues, if the patient can even read or understand the instructions or the complex information that they need to assimilate to make an informed decision. So we need to evaluate those barriers. We have to carefully look at past psychiatric illnesses, histories, present schizophrenia, bipolar disorder, chronic depression, dysthymia, any other psychiatric issues, some of which can basically disqualify them for the transplant listing. We look at the support system, not only just for the patient, but the caregivers as well. We get these patients from all over the country and overseas, and it takes a toll on the support system. So we look at as to the person who is going to be providing care to these individuals, what's going to happen to their family members and how we can help them. So that's another purpose. Then we plan a care plan for these patients, and we also spend a lot of time providing education to the patients and their family members. All of this ultimately leads to coming to the decision about the selection of those patients, and then how do we support them after that. The sources of information obviously is going to include the patients. We obviously speak with their family members. We review the outside records. We speak with their other providers, especially if they have a long-standing relationship with any of the providers outside the system. We speak with them and we discuss their experiences with the patient, if they are aware of any challenges that the patient has, any helpful tips that they can help us with, and things such as that. Sometimes it identifies the discrepancies if the patient is, for understandable reason, trying to present himself or herself in the best possible way. The components of a psychiatric evaluation is that we review the disease itself. So let's say someone has end-stage decompensated liver disease or hepatic encephalopathy, or someone has ischemic cardiomyopathy and or cystic fibrosis and such. So we discuss as to when it started, how it evolved, what kind of symptoms they are experiencing right now. It helps us down the road during the post-transplant period when someone is developing newer symptoms, so we can contrast them how they used to be. So in other words, we establish the baseline. We discuss how it got to a point where they needed to get the transplant, how they reacted to it, whether it was something which was a chronic process or it suddenly happened. We sometimes see very sad situations where everything was going wonderfully well, and suddenly within a span of 5-6 months they are very sick and they are on transplants and such. For example, amyloidosis would be one condition where the world basically gets turned upside down very, very quickly. We discuss their attitude and evaluate how they are perceiving the transplantation, what their perceptions are, if there are any misconceptions about it, how much interested they are, what kind of expectations they have, whether they are realistic expectations or they're totally unrealistic about this, if they are thinking that they're going to get the organ and then within 2 months they're going to be up and running and will be just fine, which does happen, but it's not necessarily the case all the time. So they need to be prepared for all eventual outcomes. If they have any specific concerns about getting a foreign organ, someone else's organ in their body, if they have any cultural issues with that, so we review that. We discuss as to how much they understand the transplant process itself. If our board sends them a letter which says that we are declining them because they're too early for that, they need to know what it means. What it means basically is that we say that yes, the person does need a transplant, but his merit score, which is a criteria that we use, for example, listing the cirrhosis patients, is low. What it means is that they're not as sick as someone else, and which is to some extent is a good news, and that we will keep following them up, and if their score changes, then we'll list them. Or if the person gets declined, then we have to explain to them what the reason are, and we just make sure that they know that how we reach that decision. It is very critical to for us to assess their compliance, because if they are not going to take the medications during the post-transplant period, especially the immunosuppressants, then a whole host of problems can occur, and we don't necessarily want to use a very precious resource in patients who are not going to take the medications or follow the recommendations. Sometimes, since no one can predict the future, what we have to do is to look back at the past history as to how they have responded to other medical problems, what kind of experiences they had with the illnesses and their treatment. For example, if someone had hepatitis C and was treated with interferons and ribavirin, whether they developed any problem with that. That would be an important thing to know, because sometimes hepatitis C can recur and the same treatment would be needed, and what do we do then? A lot of them have neurological and psychiatric side effects from those medications. Response to steroids is very important. If a patient has been able to tolerate them in the past, that's a good sign. If they consistently have developed problematic symptoms with that, then we prophylactically treat them. We look at current and past psychiatric illnesses. We look at whether someone has had these episodes chronically, intermittently, or they had one episode of depression 30 years ago, which was basically in response to the stresses that they had been dealing with, and now they're fine. As opposed to someone who has a history of 40 years of severe depression requiring 36 ECT sessions, that obviously is a different level of severity. We also look at the cognitive functioning and personality disorders. Cognitive functioning is very important, because if you recall, I was telling you that 29% of our patients are 65 and above, and the risk of cognitive decline continues to double basically every 5 years after 65 years of age. And in these patients who already have predispositions such as hepatic and uremic encephalopathies and such, it becomes even more critical to very carefully analyze. We do the screening test, and we have very extensive neuropsychological support available for quantitative assessment for these areas. Personality disorders is an important area to explore. Patients who have chronic and pervasive difficulty with authority figures, patients who have antisocial personality disorders, patients who have borderline personality or histrionic personality traits, need to be treated a little bit differently, and we need to know their personality diagnoses or traits. Suffice it to say that no evaluation for these patients to be listed would be complete without a very extensive substance use or abuse history. And we obviously obtain the history, and we receive information from other sources and such. We analyze their coping skills, their defense mechanisms, whether they are able to handle stressful situations well, whether they use any non-pharmacological interventions, whether they use principles of behavioral activation and self-management. So we evaluate all that. Family history obviously is important. We carefully analyze the social history and support system. We look at their educational history, we look at their employment history, we look at what their household environment is. Our financial department has a lengthy consultation with them and helps them sort those matters out. The Transplant Social Services works with them if we identify any specific issues. And as I said, cognitive examination is a very important system. In addition to the standardized clinical interviews, mental status examinations, and review of records and such, we also use some validated rating scales. PHQ-9 is Patient Health Questionnaire. It's a 9-item scale that is to evaluate the depression, the presence of it, overall improvement or lack thereof it, can be easily done by serially administering these PHQ-9s, and then we keep track of that. And it's a very commonly used tool across various specialties. The GAD-7 or Generalized Anxiety Disorder Questionnaire is a 7-scale item which looks at especially the generalized anxiety disorder symptomatology, but has other areas that can indicate presence of other anxiety disorders to some extent. Audit questionnaire is for alcohol, its current use and severity of its use. MOCA is a Montreal Cognitive Assessment Evaluation. It's a 30-point screening tool, which to some extent perhaps a little bit better than mini mental status examination that we have historically used, but they have been more recently some copyright issues and all that, so people started to have some second thoughts about that. PACT scale is a very specific scale for the transplant services. There are 8 different domains, and they get scored from 0 to 5, and the other category is unable to rate. And then after that, there's a global score, and I'll briefly talk about that at some point later. We order lab tests, and we review what's available already. That includes the urine drug screen, in addition to everything that other subspecialties have done. We also check for nicotine metabolites. We check for the metabolites of alcohol, even if it shows up negative if they have used it, we can find the alcohol metabolites. We do the quantitative assessment of any of the drug metabolites as well, so that that gives them the confirmatory test. So then they cannot claim that, I was taking protonics and it can cause false positive results. So we check, for example, THC carboxy, which is an active metabolite of cannabis, and so we can just say that, if you were using protonics, then this wouldn't be positive and such. Once we have all of that data available, what, for example, I do is that I would just sit with them then, and we'll complete the PACT. As I said, it has 8 different domains, and then we assign a global score. It's 0 to 4, so anything which is 2 and anything below 2 basically means that the transplant service is not going to consider them for the transplant. It means that they get denied. And anything above that is a good score. And so we discuss them as to why is it that we are scoring them as such and what they can do to get better. So for example, let's suppose that someone has a history of alcohol dependence and they are only sober for 4 months. Then we say that it is great that they are no longer drinking alcohol or no longer using street drugs and such, but they will need to complete a chemical dependency treatment program, and these are the components of the program they're supposed to do. Once they attend them regularly and send us all the details about that, once they completely and successfully complete that program and they continue to maintain sobriety, then we can reconsider them and such. We pay close attention to the caregiver burden issues. It's a very stressful process. As you can imagine, any chronic illness would take its toll on any family. But the transplant patients, they spend so much time in hospitals, going back and forth to doctors out of the emergency rooms and such, that it is really a full-time job for someone to be caring for these patients. And it's very easy to forget that the burnout rates among caregivers are very, very high. In Pakistan, for example, there's a lot more extended family support available. Here, sometimes that's not possible either for cultural reasons or for some very practical reasons. I mean, if everyone is working, then it's very difficult to do so. And then everyone has their own obligations and responsibilities. So we keep a close eye on this. As far as some very specific issues to transplant are concerned, please keep in mind that, by the time majority of our patients come see us, they have been to numerous places, they have seen tons of doctors, they have heard so many bad news about the illness, the prognosis, and so they're literally just barely hanging in there. It's a very stressful situation, so that when they come to see us, there's a mixture of hope, optimism, pessimism, distress, despair, all of that. So uh, sometimes they're really brittle, and then they go through this very extensive evaluation process, and rating sometimes is really, really difficult thing. Uh, just think about it. We see our patients routinely in our clinical practices in hospitals and such, and we order lab tests, and it's such a routine thing we don't even think twice about it. But for the patients, when you order the test, they already have a system of anxiety in which they incorporate another anxiety-provoking thought as to, oh my goodness, what if? What if this test shows that? What if that happens? What if the test is bad? Will that have an impact on my candidacy for transplant? What if they deny me because of this? I'm going to die because of that. So then they're anxiously waiting, and then they go to get the test done. And then if someone looks a little bit worried, the person who is doing that imaging study, for example, or if they say, oh, and then they say, oh, what do you mean by that? And you say, oh, no, nothing. The radiologist still has to review that, and we'll get back to you. Well, for that person, it might not mean a whole lot, but for that patient, now for the next several hours, or in some other cases in other centers for several days, the person is just going to be sitting there simmering in anxiety and distress, and waiting is, I've been told by my patients, is very understandably, is a really, really difficult period for them. And then it's no wonder that so many of them get depressed, and so many of them are sad, and so it's really some of it is it is understandable. Some of it is consistent with the reactive anxiety and some brief depression response, but in several conditions it becomes gets to a point where it becomes clinical depression. You differentiate that based on presence of suicidal ideation, significant amount of guilt, tremendous decline in functioning abilities, ruminative anxiety that is a lot more generalized, and there are other differentiating criteria as well. So both normal response and excessive clinical response takes place in that context. So many of them are anxious, they are stressed out, and that includes both the patients and their loved ones. If you were to look at the incidence of mood disorders, just in the patients who have advanced end-stage diseases, if they have pulmonary diseases, about 25% of them have anxiety or depression. This is not normal sort of reactive anxiety. This is where it requires some treatment. 40% of the patients who have advanced liver problem, end-stage liver disease, especially decompensated ones, they're anxious or depressed. Among the patients who have cardiac problems, 50% of them have these issues. Even after the transplant, about 63% of the patients who have heart transplant, they have anxiety or depression, and as you can see, about 30% of the patients with liver transplant and 20% with kidney develop anxiety or depression symptoms. After the transplant, especially during the immediate post-transplant period, they obviously are dealing with significant pain issues. But even before that, patients who have a significant amount of ascites and they're getting capped every week or so, they deal with chronic pain. Patients who have chronic neuropathy, they struggle with that. Patients who have hemodialysis, they deal with a whole host of problems. And the pain itself has a causes dysphoric mood. Then they get depressed, and then the pain perception increases. Then the requirement for the pain medication increases, and especially in certain centers like in Rochester, if someone is taking chronic opioid medications, they won't list those patients for transplant. So they want them off of the pain medications. The pain medications that get used, they themselves can cause a lot of mood problems and a whole host of other cognitive issues. So it's challenging to deal with the pain in these patients. The medications that are used either to treat the pre-existing conditions or the conditions after the transplant, such as immunosuppressant agents or corticosteroids, in several cases cause neurological and psychiatric side effects. Tacrolimus and cyclosporine are two medications that are immunosuppressant agents during the post-transplant. Up to 60% of them are tremulous, they are anxious, they are fidgety, they are jittery, they are restless, they are pacing, they have headaches, they are agitated. Either they have difficulty with initial insomnia or they have fragmented sleep. If they sleep, they have vivid dreams, nightmares, they have paresthesias, hyperesthesias, and dysesthesias. They develop photophobia. None of this is fun, obviously. But about 21% or so develop even worse problems. They can develop significant memory difficulties, profound distractibility. Some can have seizures, which can be treated basically with neuroleptics, the anti-epileptic medications, and they don't require long-term use of those medications. They can develop focal neurological deficits. They can develop what we call Press syndrome. They have dysarthria. Delirium is actually not that uncommon at all. I think it's not, either we see more complicated patients or for some reason delirium is a lot more common, or our hospitalists are more comfortable diagnosing it. But delirium is fairly common. Corticosteroids are interesting because they cause broad range of neuropsychiatric side effects, memory difficulties, attentional problems, mood difficulties. The patients can develop psychotic episodes, and whole host of behavioral changes can happen with steroids. And incidence is quite variable with these steroids. That's why we try to explore the fast response to steroids during our evaluation. The risk is more problematic, especially at higher dosages, at 40 milligram or higher dosages of either prednisone or prednisone equivalent steroids. And a lot of time we tend to see these patients in about 6 days or so after the steroids get started. Mood changes and swings take place with steroids, and it can happen with even the immunosuppressant agents. If someone has a history of psychiatric illnesses in the past, then it can get much worse after the transplant, and that's why we are so cautious with those patients. Mania is in particular worth mentioning because if someone has rapid cycling bipolar disorder, which means having 4 or more episodes of depression or mania within 12 months, we really don't transplant them. But someone who has significant mood stability over several years, and they're compliant with the medications, and they're well controlled on medications that we can continue in the post-transplant period, we still proceed with them. We are one of the few centers that actually does that. But even in the patients who did not have that history in the past, sometimes the medications can precipitate mania. If someone has history of these episodes in the past related to corticosteroids, then we prophylactically treat them. And it's difficult to treat because medication like lithium, for example, we can't use because of significant volume changes that are taking place. We can't use Depakote because of its effects on the liver. Carbamazepine or Tegretol is a difficult medication to use because of significant drug interactions, especially with the cytochrome P450 enzymes. And so what we use at most typically is quetiapine or Seroquel, which is an atypical antipsychotic medication in those situations. Obviously, the first generation antipsychotics, the older medication like haloperidol, still gets used and such. But it is very difficult to manage and becomes a therapeutic challenge. Cognitive disorders and delirium warrants special mention. Again, I will remind you of a significant amount of elderly patients or advanced age patients that we deal with. In those patients, either the pre-existing mild cognitive impairment can get worse, or they can develop new cognitive decline during the post-transplant period. We try to rule that out early on, but sometimes therapeutically it is challenging because if they have uremic or hepatic encephalopathy, sometimes it's difficult to say whether the cognitive limitations are because of that or because of another neurodegenerative process. In the patients who have very low scores on MoCA, which was the Montreal Cognitive Assessment, we end up getting some very detailed structured neuropsychiatric assessment done, and sometimes that we are able to tease that out. Press or posterior reversible leukoencephalopathy syndrome can happen because of immunosuppressant agents, or it can happen in patients who have uremic encephalopathy. The symptoms, there's a wide spectrum of the symptoms that can happen in any of these conditions, from very minor symptoms to full-blown confusional states. For anyone who doesn't like mice, which includes myself, my apologies, but the reason that I included this is that a lot of time patients who have delirium or psychosis, they start having visual hallucinations, which a lot of time or most of the time are because of organic reasons. For those patients, these hallucinations, we really need to remember they're just as real and as disgusting or as scary as, for example, these mice are for us. They really see these things, and it is very disconcerting for them. They develop delirium, and you go in, and there's the time someone is mixing poison in their food, their sleep-wake cycle is all out of whack, and I mean, it's a real difficult time because they don't want to take any medication, they stop eating, they don't want to go to any physical therapy and such. So it requires quick and aggressive treatment quickly. Paranoia gets its fair share represented in those patients too. As I mentioned, they really get scared, and in their while they're in and out of their confusional stage, sometimes they confuse things and sometimes they misperceive things, but whatever it is, they incorporate the whole thing into an overall narrative of this persistent paranoia, and then, as you can imagine, it becomes very tricky. Because of all of these things, who wouldn't be afraid if people are coming out of the walls and someone is trying to poison us? So they're very, very afraid. So then they stop telling things to their care teams. They don't want to take any medication. They're trying to run away from the hospital while they have all these infusions and all the medications going, and they're attached to 17 different tubes and such. So it is pretty difficult to manage at that time. So that's when we end up using high dosages of IV benzodiazepines and along with that antipsychotic medications and such to calm them down quickly. Alcohol use during, obviously not during, but before and after is a major issue. When they see us, obviously at that time they are swaying up and down, and they would never relapse. But this is an addiction for a reason. The risk of recidivism, which is the relapse among these patient populations, is there. Whether it is extremely high, it's difficult to say. The more rigorously designed studies show up to 6% of the patients relapse after the liver transplant. Some people think it is underrepresentation, but I cannot tell you what is the specific percentage of patients who relapse. But nonetheless, we really keep a very close eye on that. Nicotine is a bit more complicated than alcohol because there's not a broad agreement about how to deal with that post-transplant. In our center, we want the patients to be non-smokers. We monitor for the nicotine metabolites, and the transplant surgeons in particular are worried about the healing and the post-transplant outcome in patients who have chronic smoking. So we do not want our patients to be smoking at all, and we are fairly clear about that. We have to keep in mind that fortunately, majority of us don't wake up every morning thinking about, is this going to be my last day? Am I going to die within a week? What happens if I don't get the organ and I die next month? So these guys are dealing with this process. Death is staring them in the face, and the process of dying is not that fun thing. Especially if someone does not have the religious beliefs or faith or some sort of supportive system, if they don't believe in afterlife and that's it. So to them, this is it. So party's over. So that's why they have so much angst and anxiety about it, and it's just no fun. And that's why, if you were to ask me what is the most important thing that any of the physicians who is working with these patients can do, whether they are transplant surgeons or psychiatrists or anesthetists or whomever, is to instill some hope that, at this dark place where they are at, that despite the challenges and such, that there is still hope, that we can make things better for them, that we can help them get through this difficult time to the best of our ability. And a lot of time we are able to do few things for them, even when the situation does not appear all that promising. The other thing that we do, and I won't go into detail, is that we do the donor evaluation as well. And it has its own detailed protocol as to how we go about doing it. There are a lot of similarities though. And in this situation, we are acting as a donor's advocate. We are looking out for his or her interest. And people have the option on their driver's license to indicate whether they are donors or not, and that helps the ER teams to determine what to do with them and how to approach their loved ones if they are in a state where they can be the donors after their death. With that, I will conclude my presentation, and I really would like to thank all of you who took time to come here, and hopefully I was able to share a few things with you guys that were of some interest to you all. And with that, I will open the session for any questions, any discussion and such. Thank you.
Thank you, Dr. Niazi. Can you hear me?
Yes, I can.
Yes. Okay. Thank you, Dr. Niazi. I'm Professor Razaur Rahman. I'm Chairperson Psychiatry at Dow University of Health Sciences. With me is Dr. Naeem Siddiqui. He is basically a consultant psychiatrist at Sindh Institute of Urology and Transplantation, and he is dealing with many cases of transplantation over here. And this is a very nice presentation, and I have one question simply, that what is the reason why what we think that the perception is the same, that our organ is being transplanted, but there is a huge variation in psychiatric morbidity with the different organ transplantation. What's the reason behind that? Is it simply psychological reason of the loss, or something biological which is acting behind that?
Well, excellent question. What we think is this, that if you think about the organs, for example, which if I were to just simplify the whole thing, the organs that are acting as filtering agents for certain agents that can cross the blood-brain barriers and such. Let's say the patients who have liver, decompensated liver disease, because of all the chronic ammonia levels and all the other toxins, if they are already crossing the blood-brain barriers and they already have chronic encephalopathies and such, there's some concern that some of the changes that are taking place are neurotoxic, and as a result, you tend to see a lot more comorbidities during the post-transplant period in those patients. The other thing is that some of the risk factors for these very diseases are pathological in nature. Let's say chronic drug usages or chronic alcohol usages, they predispose these patients for more complications down the road. The other thing that happens is that these things can precipitate some of the psychiatric illnesses during the pre-transplant period, and as a result, their predisposition to have those problems after the transplant increases. Someone who has lived a wonderful life and has been very healthy but was unfortunate because they developed an infection or something and their kidney got affected and they need a kidney transplant, those patients are going to be better off as opposed to a 65 years old with a history of using alcohol for 35 years. Does that answer your question?
Yes, I think, and Dr. Naeem Siddiqui is here. I think he wants to ask something.
Sure.
Dr. Naeem.
Dr. Niazi, thank you very much for a very comprehensive and very useful presentation, specifically for me. I'm exclusively working at this unit, and perhaps I'm the only one in Pakistan who's working in a transplant unit, exclusively as a psychiatrist. And you can just imagine the burden. Although we do not do other transplant, but we have, as opposed to Mayo Clinic, have done well over 3,000 kidney transplants. Therefore, I do come across a lot of things. I would also say in a sort of comments that I fully agree your recommendation to medical students about the liaison psychiatry. Other than what you have already said, I think that perhaps that also puts us, the psychiatrists, back into, in inverted commas, the doctor's role, rather than the differentiation between the psychiatrist and the doctor. Having said that, I would like to sort of ask you that, have you noticed the beneficial cognitive changes after transplant?
Yes. Absolutely, especially in patients with the chronic encephalopathy. You know, we are going to be, right at the moment, it's interesting you say that, because in our transplant research group for the last 2 months, we are going back and forth about trying to figure out a way to do a longitudinal prospective study in these patients to see if just from a quantitative assessment standpoint, whether these things actually quantitatively improve over time or not. Because there's a group of physicians that believes that there is a point that if you don't transplant these patients at that level, that some of these changes might be actually somewhat irreversible. We don't know what that cutoff point is, but there is rather marked improvement in encephalopathy patients once they have had the liver transplants and all that, and sometimes it is remarkable. And patients who have, for example, chronic hypoxemia because of the end-stage pulmonary disease, those patients after the lung transplant, they start to feel much better as well. The same is the case with the cardiac transplant patients. But these patients are already using, in the case of liver patients, a horribly expensive medication called Xifaxan, which after the insurance pays the portion, it's about, I think, $500 a month, the tablet just for encephalopathy. And after that, after the transplant, they're not using it, and they're actually more clear than they were when they were taking that medication.
What about the use of this instrument, a Montreal Assessment Scale for Cognitive Assessment, which you were saying that because of the these rights you were not able to? Why that is more beneficial over the mini-mental state?
Well, in that there's an additional component which assesses for the word fluency, and the clock drawing is already part of that test. And then the digit repetition is of 2 different kinds. And then the other thing is that the delayed recall has 5 words as opposed to 3. There are 2 complicated sentences that need to be repeated as opposed to no ifs, ands, or buts. Okay. And the sentences that are used are basically that cat always hides under the bed when dogs are in the room. And the other sentence that gets used in that is that John, I know that John is the one to help today and no one else. And so they're a bit more complex. Plus the abstraction is already there. So we are looking for the category test as a part of that, in which we give them a cue for saying that how an orange and apple are similar to each other because they're both fruits. So it gives them a cue that we're looking for category, and then ask, so how is a bicycle and train similar to each other? Or how is a ruler and something else are similar to each other? So one is the measurement, and the other one is that we're looking for the modes of transportation. So it assesses some of those executive functioning areas a little bit better. And the other thing is that it is in public domain, so you don't have to worry about the copyright issues and all that, which as you can imagine, is a mess. And it never used to be an issue, but suddenly, like 4 or 5 years ago, the psychologists who came up with that became very gung-ho about it, and so we as an organization decided that we're not just going to get involved into that, and we started using this.
Okay, I'm aware of other people might be waiting, but I would love to come back. I don't want to take their time if there is a time at the end of other people's questions.
I would be happy to. And the other thing is that send me an email if any questions, any concerns. It's my last name, Niazi .Shehzad, SHEHZAD @mayo.edu.
I would perhaps have to take it because I wasn't paying the attention, so I may miss a word if okay. Our IT person, I think, will take care of that. Thank you very much. I would certainly be in touch with you.
Absolutely, my pleasure.
Assalamualaikum, Dr. Shehzad. I'm Dr. Aisha Sarwat. Can you hear me?
Yes, I can.
I'm from Dow Medical College, assistant professor in psychiatry. Just a simple question that you said about transplantation, the depression and anxiety. So do you use the antidepressants and all those things before the transplant? And do you use the psychological methods also? So which is the preferred one? And what happens if the patient is not compliant with the medication? So this must be a very difficult task to go for before transplantation and even after transplantation.
Well, the
improvement of the compliance and all those issues also.
Great question. The way I approach this question is this: that I tell my patients that the treatment plan is going to consist of several domains: biological, psychological, social, and people who are so inclined spiritual aspects of things. And I tell them that I will discuss the medications at the very end, because I believe that unless we pay attention to the other areas, the medication management by itself does not or cannot achieve the mission. So in psychological, we discuss the basic concepts of mindfulness, basic concepts of cognitive behavioral psychotherapy, non-pharmacological interventions such as passive muscle relaxation, deep breathing exercises, role of meditation, people who are so inclined, who are very new agey nowadays, they do yoga and stuff. Then in social domain, we talk about behavioral activation and self-management. The components of that are assertive socialization, which is different than just hanging out with friends, and physical activity on a very regular basis, such as regular exercise. And we discuss ongoing regular participation in pleasurable activities. People who are spiritual and are struggling with theological issues or metaphysical issues or are into meditation, we reinforce that. And then we talk about the medications. Among the medications, we try to avoid the medications that have too much drug interactions, such as fluoxetine or fluoxamine, for example, or paroxetine. The medications that have lower side effects are going to be Lexapro and citalopram, for example. Remeron is something that we use as well. Zoloft is used as well. Some of the medications require dosage adjustment. The rule of thumb is that it's easy to remember, just half of the standard dose usually works well. And then what we do is that these patients who are coming to see us initially, they are extremely motivated, because they know that they have to do all these things in order to get to the transplant. So we have a significant sort of structure for them. So they do very well. They're awesome. You ask them to do it, bring the record back to you, they bring it in like 3 copies of that. After that, and it's in their best interest too, so they do that. After the transplant is a different story, but majority of the people find the medications helpful, and since they're taking so many other medications, that they continue to take psychiatric medications. But it would be naive to expect, or for me to believe, that compliance is great. As you know, in general, compliance with the psychiatric medication is not awesome. But at the end of the day, these patients are adults, and they have to make a decision for their own good as well. And they should be working hard at getting better more than I or you should be working at making it better.
I think, thank you. We want to give chance to other people. Thank you very much, Dr. Niazi, and I hope that next Pakistan, we are inviting on the behalf of Dow University, visit Dow University, and we want to collaborate with you in the future, particularly in respect to research. So thank you very much from Dow University.
You are very welcome, sir. My pleasure.
Hello. Niazi, do you hear me?
Yes, I do.
Hi, sir. My name is Dr. Aftab Asir, Professor of Psychiatry in King Edward Medical College.
Sir, you may not recall me, but I was for 2 months there at Mayo just before I left.
Thank you very much for so much new information for us here in psychiatry. This specialty is completely new for us, especially from here in King Edward. Perhaps in Dow, they knew about board transplant there here rather than there in Lahore. So it's more information rather than, we knew about liaison psychiatry, but not really that like transplant psychiatry. So thank you very much for giving so much more information to us.
You're very welcome.
Thank you.
Just briefly, what it is that the consultation liaison psychiatry, obviously it has a few years ago became a recognized ABMS subspecialty by the name of psychosomatic medicine. And in the psychosomatic medicine, now it has evolved to the extent where there are areas. So I am in the tertiary care division of the psychosomatic medicine. So all of our practice is consultation service. And so what I do is that, yes. Yes, please go ahead.
Sorry?
Yes.
I'm still listening.
Oh, okay. So for example, I closely work with the group, or we have like 40 oncologists, so I work with their patients too. But in that, there's further subdivision. So there are some patients who are just people who are just focused on bone marrow transplant portion of it. So, and then there are people who are just for amyloid doses. So, like for example, one part of my responsibility is working with the amyloid clinic patients, and so it has depending upon sort of the center where you're working at, there are some of the subspecialties that are available, and that's why I decided to speak about this, because a lot of time when we are thinking about psychiatry, we don't think that we'll have an opportunity to work in these type of areas.
Right. Psychosocial psychiatry, as you know, is very common here in Pakistan. But is it psychosocial psychiatry a bit different from transplant psychiatry, what you are saying?
Psychosomatic, it's not, it's consultation liaison psychiatry when they were becoming a subspecialty in which you have to take a board, just like you take a board for a general adult psychiatry or child psychiatry. There's a separate board certification for and training fellowship program. So instead of calling it consultation and liaison psychiatry, the official name of that subspecialty is psychosomatic medicine. It's not psychosocial, it's psychosomatic.
Anything new?
Hello. Hello.
Yes.
Can you hear me? Yeah.
Yes, I can.
Okay. I'm Dr. Nazish. I'm a consultant child and adolescent psychiatrist at King Edward Medical University. And thanks a lot for the excellent presentation. And what I want to know is, does your clinic deals with transplantations related to children as well? And how does the assessment process when you're dealing with children differ from that in adults? Because obviously you are not only dealing with very frightened and anxious children, but you are dealing with their parents as well, who understandably are under a lot of emotional stress as well. So if you can please elaborate on that.
Great question. We don't see the market where we are in. We have like a huge 4 or 5 children's hospitals just within like 25 miles radius of our clinic. So we don't have the child and child division here. So all of those patients are treated in Rochester, and they have a completely different division for that, and they have about a dozen or so patients, physicians and psychologists and therapists who work in that division for that very reason that you're mentioning. And it is always challenging. I mean, I have the greatest regard for child and adolescent psychiatrists. I couldn't do it because I always was more irritated by the parents than anything else. And it is very challenging situation because they are so anxious and they are so worried and apprehensive that you don't have one patient, you have a handful of patients in any situation. So it's entirely different way of approaching them. They have they even use completely different terminologies to explore these things, and a lot of evaluation gets done in a play group type sessions and such. They have a whole host of techniques that they have developed specifically for that, but it's not my area of expertise, so I don't know much about that.
Thank you very much. Anyway, thanks a lot for highlighting this extremely important area of consultation liaison psychiatry. Thanks a lot.
If other centers have no question, then we have more questions from Dow University, particularly Dr. Naeem Siddiqui, because he is dealing more with such patients, so he wants to ask a few more questions. Dr. Naeem.
I hope that I'm not taking the time of other people. I just wanted your comments, because one of the things which I observe here a lot is the dermatological side effects of the immunosuppressant and steroids, and the anxiety and the difficulties which is associated with them. how about your center and specifically the strategies to use to deal with the psychological impact of those dermatological side effects?
Well, you know, one disadvantage, or and to some extent one advantage of working in areas where there are so many different people working is that you kind of sometimes develop a tunnel vision, you know. So anytime someone has those like dermatological issues and all that, it's basically referred to see a dermatologist stat while they are here, and then we focus on how we help them with the anxiety that is coming from that. And so some of them end up getting doxepin, you know, which obviously is going to help them with the itching and related issues and help with anxiety, sleep, and all that. We do have some therapists that we have these patients work with them, and as I mentioned, they learn some very specific relaxation techniques. And a lot of time, if they start using those techniques effectively, sometimes they don't even need medications to treat that. And the other thing that happens is that the way I approach this situation is that by the time my patients start worrying about acne and skin rashes and things like that, is that to some extent they're getting over their concerns about dying and death. That in itself sometimes is a sign of progress, that in the big scheme of things they're worried about that. But we just treat that anxiety stemming from that just like any other anxiety stemming from any other medical condition.
What about, you mentioned earlier in your lecture using quetiapine to treat perhaps some of mood disorder or the psychotic symptoms. But what I found that a good range or a great proportion of the people do develop metabolic syndrome secondary to steroid and immunosuppressants. And this is one of the medicine which also known to cause weight gain.
Yep.
And it's a big issue here with the center where I am working. So do you come across that? And if that happens, then how does it make any changes in your regime of you treating those psychosis or mood disorder?
What I do is that I clarify to the family members in that situation that the acute treatment is going to be perhaps different than the long-term treatment. And unless someone has chronic psychiatric illnesses to begin with, and they develop these symptoms during the post-transplant period, they don't necessarily require ongoing treatment, at least in our experience. So we treat them acutely and then they get tapered off of those medications, and the majority of them are just fine. Just like patients who develop seizures who are using immunosuppressants, they use anti-epileptic medication for a short while and they don't require long-term maintenance in most situations. So sometimes it's not too much of a problem. But with the longer-term use, it does become an issue, and we obviously keep a very close eye on it, especially considering that they're already on steroids. So they are getting hit pretty hard by these medications with metabolic impact. In those situations, obviously, Abilify potentially can be used as well. We just use whichever medication we can based on whatever risk factors there are. We do stay away from Geodon in a lot of situations because of concerns with the QTC interval, but even sometimes that gets used as well. Good old Haldol still works fairly well, you know, and but if there is issue with the metabolic syndrome, we switch to Abilify.
You did say about use of benzodiazepine. I wasn't sure. I probably missed that point. Do you use benzodiazepine in delirium, or you were mentioning the use of benzodiazepine in other situations?
We try to stay away from benzodiazepines as much as we possibly can. The time when we use it is if patient is extremely agitated and such. So a lot of time, even before we get there, the intervention, the intensivist or one of the surgeons has already given them the Haldol and Ativan combination, and we use that. We try our best to stay away from benzodiazepines. None of the psychiatrists in our group really likes them that much. And that's why sometimes Circle works really well, because it in itself has norcotiapine, which is the active metabolite and has anti-anxiety properties, so it does have some calming effect. And sometimes I end up just using Zyprexa if I have to just control the agitation quickly, because it is available as an intramuscular injection, as a sublingual tablet, and as the regular tablet. So it just depends as to what's going on. But no, we don't like to use benzodiazepines.
Thank you very much for a very comprehensive answer as well. Just to sort of end and comment on Dr. Aftab's comment about psychosocial, I think our psychosocial aspects are pretty different. For example, what you have mentioned about the support to the caregivers. Here, mostly the person who is going through the transplant may be the earning member, and there is a lot of pressure on that. Similarly, as the medical services are not that developed, same is the issue with the psychiatric services, and then a subspecialty under that, which needs a lot of persuasion. You could probably devise that chart, and I was very happy to see when someone scores 3, it's a yellow thing. But here you have to be much more persuasive to say that why do you think that it may not work, to the family as well as to the physicians and surgeons.
I couldn't agree with you more. You know, I really don't envy your situation. I don't know what I would be doing, to be honest with you, in those situations, because especially the climate right now in which, I mean, you know, media is a double-edged sword. It keeps you connected, but it also paints the sometimes very bleak picture. I mean, you keep hearing these things and reading about how the upset family members are, you know, just chasing the physician and such. So it's a very complicated, complex issue. And you know, here that's why I was mentioning that here in U.S. it is so significantly regulated, and there are so many guidelines and all that around the solid organ transplant that you can always point out to them, you know, that there's nothing personal. I mean, this is what it is. And we are just lucky that we are practicing the setup that we are practicing. But what you're saying is absolutely spot on. It's very difficult. How can you tell someone that, you know, you're going to refuse them a kidney based on their psychiatric aspects? So many of them are not going to even put much stock into what we are telling them.
And sometimes even some of the more enthusiastic colleagues, they ask them not to tell the psychiatric history because you might be deprived of from the transplant. So it becomes even so it becomes even more difficult.
Yes, they have the surgeon's edge. So
Yeah.
we have some of that here. But no, I mean, most of the time, see again, I mean, it's the outcome. What happens here is that it's over time, all these enthusiastic surgeons, they have realized they have been burned so many times that now we have to be so exceedingly careful as to what we put in the patient's record, because they just look at it, they latch on to just one word, you know, in like 10-page worth of evaluation, and you have to just explain to them that no, we are not saying that this is not a good candidate, we are saying that this needs to be addressed. So it takes time.
Okay, Dr. Niazi, it was wonderful to talk to you, and I would certainly be in touch, and definitely I would like to collaborate with you in terms of the research and taking some guidance, because here in Pakistan, if I ask any of my colleagues, he said, we are going to ask you the question, so I need someone who is more experienced than me here. So thanks a lot for your wonderful presentation, and I give it back to Professor Raza for formally thank you for your presentation.
You're very kind. Thank you. Pleasure talking.
Thank you, Dr. Niazi. It was really a very wonderful, and it was very good to talk to you, and hope that we will very soon hear from you. Thank you very much.
Inshallah. Thank you for your hospitality and time. I really appreciate that.
Thank you very much, Dr. Niazi. Good night.
Daniel sir, are you still online?
Yes, I am. जी हेलो
हाँ जी, अस्सलाम वालेकुम।
जी वालेकुम सलाम जी जी I'm here.
So everyone is done, right? I can disconnect.
जी बिल्कुल.
Thank you. बहुत शुक्रिया.